Welcome back, everyone. Today we are talking about a phenomenon every single person on this planet has experienced, hitting your funny bone. But as any medical student quickly learns, it is anything but funny.
Exactly, Dr. Khan. And while we call it the funny bone because of its proximity to the humerus, what you're actually feeling is a transient paresthesia of the ulnar nerve. From a board exam perspective, this is a high-yield goldmine because of its very specific anatomical course and the predictable deficits that occur when things go wrong.
Right. I like to think of the ulnar nerve as the medial traveler. It starts in the axilla, moves down the arm, but then it has to make a sharp turn. It's like a car taking a hairpin turn around a mountain cliff. That cliff is the medial epicondyle of the humerus. Dr. Sara, walk us through the precise route it takes there.
Precision is key here. The ulnar nerve originates from the medial cord of the brachial plexus, carrying fibers from C8 and T1. It descends the arm on the medial side of the brachial artery, but halfway down, it pierces the medial intermuscular septum. That's where it enters the posterior compartment before sliding into that shallow groove behind the medial epicondyle, which we call the ulnar sulcus.
And that is why it's so vulnerable. Most nerves are tucked deep under layers of muscle or bone, but at the elbow, the ulnar nerve is just sitting there, right under the skin, buffered only by a bit of fascia. It's basically an exposed electrical wire. Why does this matter clinically, Sara?
It matters because it's the most common site for nerve entrapment in the upper limb after the median nerve. This is the cubital tunnel. If you have a patient with a medial epicondyle fracture, or even someone who just leans on their elbows too much at their desk, what we call student's palsy, that nerve gets compressed. On a step 1 exam, they love to ask about the specific sensory and motor losses associated with this exact location.
Let's talk symptoms. If I whack my elbow right now, I feel a zing. But where does the zing go? It's not the whole hand.
No, it is very specific. You'll feel it in the medial 1.5 fingers, the little finger, and the medial half of the ring finger. If the lesion is at the elbow, you lose sensation on both the palmar and the dorsal sides of that area, because the dorsal cutaneous branch often hitches a ride past that point.
And that brings us to the motor side. This is where it gets clawy. I always tell my students that the ulnar nerve is the musician's nerve, because it controls all those fine, intrinsic movements of the hand. If the nerve is damaged at the elbow, what happens to the hand's appearance?
You get the classic ulnar claw, or main ingriff. But listeners, pay attention. There is a paradox here. If the injury is higher up at the elbow, the clawing is actually less severe than if the injury were at perist. This is the ulnar paradox. Dr. Khan, can you explain the clinical logic behind that?
Think of it like a pulley system. The ulnar nerve supplies the medial half of the flexor digitorum profundus, the muscle that curls your fingertips. If you damage the nerve at the elbow, that muscle is paralyzed. It's limp. So the fingers aren't being pulled into a tight curl. But if the injury is at the wrist, the FDP is still working. It's still pulling those distal joints into a tight, angry claw. It's counterintuitive, but a better-looking hand often means a worse nerve injury higher up.
That is a favorite board question. Now, don't forget the other muscles. The ulnar nerve supplies the flexor carpi ulnaris, so if you ask the patient to flex their wrist, it will deviate laterally toward the radius because the ulnar side has no pull. Also, the interossei. Dr. Khan, what's your favorite way to test those?
The paper test, or Fromen sign. I give the patient a piece of paper and tell them to hold it between their thumb and index finger using only their adductor pollicis. If the ulnar nerve is dead, they can't adduct the cum. Instead, they'll flex the tip of their thumb using the median nerve's flexor pollicis longus to compensate. It's like they're trying to cheat the test.
Exactly. And for those of you preparing for clinical rotations, being able to spot these subtle compensations is what makes you the doctor of choice in a busy neurology or ortho clinic. You aren't just looking for what they can do, but how they are doing it.
So why does this matter clinically when we look at trauma? Let's say a kid falls and gets an avulsion fracture of the medial epicondyle. The piece of bone literally rips away, and the ulnar nerve is right in the line of fire. Or an elderly patient with osteoarthritis. The bone spurs in that ulnar groove can slowly, over years, saw away at the nerve.
And let's not forget the intrinsic muscles. We're talking about PAD and DAB, palmar interossei adduct, dorsal interossei abduct. If you lose the ulnar nerve, you lose the ability to spread your fingers or pull them together. You'll see hollowing of the back of the hand because those muscles atrophy. It looks like the skin is just draped over the metacarpals.
It's a devastating injury for a pianist or a surgeon. To wrap this up, if you're ever in the ER and you see a patient who can't cross their fingers or numbness in that pinky, look straight at the elbow. Check that medial epicondyle. Check for a history of leaning on that arm.
Great point. Let's summarize the high-yield takeaways. The ulnar nerve comes from the medial cord, C8T1, travels behind the medial epicondyle in the ulnar sulcus, and enters the forearm between the two heads of the flexor carpi ulnaris. Injury at the elbow causes sensory loss in the medial 1.5 fingers, a weak grip, and the ulnar Callahan deformity.
And remember the ulnar paradox. A higher lesion at the elbow results in a less dramatic claw because you lose the FDP muscle's pulling power. Thanks for joining us for this deep dive into the funny bone. Stay energetic and keep connecting the anatomy to the patient.